بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. Ramadan Mubarak to everyone. So Ramadan blessing to every one of you. So I would like, in behalf of the Saudi Society of Nephrology and Transplantation, welcoming all of you, and I would like to thank you all for trusting all the scientific activity that conducted by the societies. I would like to disclose that number of registered on this webinar is over 11,000 who's registered in this webinars. This is make a lot of pressure on us that we continue moving up by the high caliber talks and presented by high caliber speakers. And as you know, this topic about the autosomal dominant polycystic kidney disease is one of the unfortunately causing renal failures in Saudi Arabia and in our Middle East regions. So I will not take long time introducing our colleagues, the speakers, and our moderators. So I will leave the mics. Before I leave the mics to our colleagues, I would like to thank Spimaco for sponsoring this event. Without their generous sponsoring of this event wouldn't be happened. So thank you very much, Spimaco, all of them, and one of them, my brother Abu Hassan. So the mic's with you, Dr. Faisal. So you can start moderating the session.
يديك العافية Prof. Khalid. Assalamu alaikum wa rahmatullahi wa barakatuh. Kul aam wa bikhair. My name is Faisal Basumbul. I'm a transplant nephrologist from King Faisal Specialist Hospital and the program director of the Transplant Fellowship Program. I have the absolute pleasure tonight of introducing Dr. Rupesh Raina. Dr. Raina joins us from Cleveland Clinic. He's a staff adult and pediatric nephrologist and is a professor of medicine and pediatrics as well at Northeast Ohio Medical University. Dr. Raina will talk to us about the important topic of Tolvaptan use in ADPKD, in which he's well published. And I would appreciate if you can leave the questions in the Q&A, and I will go over them at the end, inshallah. Dr. Raina, please go ahead. Thank you.
Good evening and good night to all of you. First of all, I want to really wish you a very happy Ramadan. My special thanks to the Saudi Society for giving me this opportunity to talk. My special thanks to Dr. Medwali for his welcoming approach to us and our collaboration. And last but not the least, my friend, my brother, Khalid Al Hassan, who has been working with us in collaboration with PCRRT Iconic. He's one of our board members. I really want to thank you all for giving us this opportunity and also for the collaboration that we have established with Dr. Metwali and Dr. Al Hassan. I'm going to talk about the critical path to the novel development for the ADPKD. And this story is actually a story of my whole career, because when this drug was developing, I was a fellow, and this was my research that was ongoing when I was doing my fellowship. So it's not too far, but recently there's a lot of growth on the what you call as the renal cystic disease. I would recommend all of you to read this core curriculum in nephrology, where we talk about the diagnosis and management of the renal cystic disease of the newborn. If you look into the pathophysiology, it's very fascinating that it's actually a ciliopathy, and how the ciliopathy and the cilia of the epithelium of the cyst growth has modified over the time of 12 years, that you have multiple cysts which has been now used or have been identified at the pathophysiology of the cystic disease. Some of them at the time was polycystin 1, 2, but now you have, and fibrocystin, but you have a lot of other genes like nephrocystin, inversin, nephrocystin 3, 4, 5 has been evolving, and multiple research is going on these ciliopathy. The issue is when you see these cysts, it's very hard at that time to find the pattern, because most of the time, even you get consulted is when the patient is in utero with the maternal fetal medicine, or they are born, or they are seen during their adolescent or later early childhood. I think this is a nice article, how it classifies the cyst and the pattern of the cyst which is being found in the renal ultrasound. because most of the time when you get a renal ultrasound, it says cyst, and clinical correlations are required. So I'll highly recommend you to read this article. Solitary cyst, single cortical cyst, you're talking about segmental multicystic dysplastic extrarenal cyst, or you're talking about dilated dysplastic upper pole of the kidney, maybe cystic tumor or beginning of the PKD. But we have multiple unilateral cysts, then it is definitely MCDK. And some of the differentials also have to look around. Is the cystic dysplasia with or without, um, uh, with and without obstruction, or unilateral beginning of other cystic disease? I think the bilateral cyst or hypoechogenicity without oligohydramnios, your differentials are going from ARPKD to HNF1 beta to Meckel-Gerber. You can go to nephronophthisis, tubular dysgenesis. But if you have bilateral cyst or hyperechogenicity, because sometimes these early cysts, they have the echogenicity of the liver. So that's why it's known as hyperechogenic. You're talking about the ARPKD syndromes or bilateral cystic dysplasia. The differentials are the ARPKD with, there are certain in utero cases which has been published in NEJM about ADPKD, specifically with two hypermorphic mutations. You're talking about Meckel-Gerber syndrome, metabolic diseases, or you're talking about lower urinary tract obstruction. There's a lot of issues in the classifications, and this is an ongoing issue about the classification. Are we going to classify renal cystic disease on the pattern of inheritance? And this is a nice review article where we talk about maybe we have to locate these genetic diseases on the basis of the gene locus and their clinical features and the protein that is involved. And this is the first way we classify it. For example, one hippolindoid disease was VHL 3P26. It has multiple renal cell carcinoma, renal cyst. It has hemangioblastoma, angiometa of the retina, liver, lung present with visual CNS abnormality. Are we going to do that on the basis of the clinical features and the genes? That was the thought process for the classification. A simple example is Bardet-Biedl syndrome, where you have the BBS gene, which is 14 different kinds. It has enlarged hyperechogenic kidney, absence of the corticomedullary differentiation, and there is digital abnormality, delays onset of the classic symptoms. This was a classification was evolved. Then it came out the renal cystic disease of the newborn. Maybe we have to talk about just not about the pattern of looking into the pattern of summary, but we are looking into the inheritance, how those can be differentiated. So this is autosomal dominant. Let's talk about the autosomal dominant polycystic kidney disease. And one thing you need to be very, very clear that it is an inherited disease characterized by the development of progression of the enlargement of the fluid cyst within the kidney, but 50% of chances of passing towards the next generation. Now, this is something, an old concept that came out, that 85% of the disease of ADPKD is due to the PKD1 and 15% is due to the PKD2 mutation, which is less truncated, progress less. But the things are evolving when we are looking into the ADPKD registry. Actually, we are finding no family history, almost going back to like 25 to 30%. Now, why ADPKD was the center of attraction for all the other renal cystic disease? It is most common inherited renal disease. It is responsible for 4.5% of the ESRD cases in the United States. It is the fourth leading cause of ESRD in the United States after diabetes, hypertension, and glomerulonephritis. An estimated prevalence of the ADPKD for US population is 4.3 per 10,000. Around 140,000 patients were currently diagnosed at the time when the research was going on. So it is not a subtle disease. If you go back into the previous era, people was not believing on the concept of the ADPKD disease. And PK like, okay, with diabetes and hypertension is the most common disease. But if you see evolving just in US, the population, it's pretty high. Now, if you look into the ADPKD progression with a high interpatient variability, and this is my problem when I talk to the nephrologist, They have a patient who's 21-year-old, and the patient is just doing well, but that patient has a kidney size of 14 centimeter. Creatinine is around 0.8. The GFR is 110. The problem in the ADPKD progression is that some patients, they progress fast, but their trajectory is different than diabetes and hypertension because they hyperinfiltrate first and then they impair, and then the renal progression goes on. When I see a patient of a 14 centimeter size of kidney with an eGFR calculated more than like 110 or 112, I will say that patient is going towards the direction of impairment, and that hyperfiltration will lead to the progression of the renal disease. And guess what? After 2 years, I see these patients, the GFR is almost 60 and they are progressing. But this is a problem of the ADPKD progression versus the normal diabetes or anything else. ADPKD is characterized by both the renal and extra-renal manifestation. And this is something very, very important people should know, is that it is a syndrome. It is just not ADPKD. You have subarachnoid cyst, you have valvular disorder, you have hepatic cyst, you have pancreatic cyst, you have renal cyst, you have palpable kidney. And this is a nice paper we published about the autosomal cyst polycystic kidney disease with the heart and brain. There is a lot of things with the hypertension looking into the cyst. I can tell you that the incidence of the aneurysm in patients without family history is around 2 to 3% or 3 to 5. And you have a higher chances of getting intracranial aneurysm is when you have a positive family history. It's a beautiful article, and it shows that the ADPKD is not benign. It has a lot of other mechanisms that just not only activate the ACE and R, but also there is a potential of causing the left ventricular hypertrophy. There is an involvement of the endothelial receptor. So that's why I said this pathogenesis of the ADPKD is pretty high. How would you diagnose? Now, this is the criteria. You all know about the Ravine criteria. And for equivocal, it shows the MRI results of the Ravine criteria is very much mapped with the renal ultrasound. If you have a patient, here is the diagnostic criteria, 15 to 39, more than total 3 unilateral bilateral, 40 to 59, more than 4, 2 within each kidney, total 8, more than 60 years, 4 within each kidney. This is very well defined in the adult, but in children's, the issue was above 15, I can count that at 3 unilateral or bilateral, but below 15, what is the criteria? And we came up with an article and a review where we shows if you have a family history, positive family history of the ADPKD, or even like 2 generations above, you have any cyst, like 1 or 2, and if you have hypertension, those are the criteria that you label them ADPKD. The problem is in the children's, most of the time it's an incidental finding because they don't have any symptoms. I see them for hypertension and the cyst is sitting there. And also these are microcysts in ultrasound. You never know how much macrocysts they have in the kidney ultrasound. What you see is just the macro, but micro you can always see it in the setting of the MRI. And genetic testing is not always required, maybe helpful. Imaging results are uncertain, but the problem is that you have to be very careful that these genetic tests has to take in with the grain of salt in the later stage, but in early maybe it's helpful. And now we have this Natera that you can take the test of the swab of the mouth, and then they can just go and we can assess whether there is an ADPKD or not. I'll give you a very simple example. I saw a 16-year-old girl who came to my clinic, has a little bit of protein, abdominal pain. There were 2 large cysts on the kidney, no family history, and abdominal pain, little bit of blood in the urine. And I talked to the family, I took a history, everything was normal. There was no history of any renal cystic disease. And that's a condition. I did a renal Natera genetic test, and it was full penetrance of the polycystin 1 disease. and she had ADPKD. So in that case, when in the younger patients, the genetic test is more important, but I just want to let you know the ultrasound criteria map very well with an MRI, and it has a very good specificity. The pathogenesis is actually very different for ADPKD. PKD1 or PKD2 mutation leads to the defective PC1 and PC2 protein. The cyst forms and they form an epithelial cell proliferation. Fluid causes cyst to balloon out and pinch off of the individual nephron. An inner medullary cyst potentially diminish the urine capacity, the concentration defects. The biggest thing that we see in the renal cystic development was very fascinating because I was a fellow, and I'll show you this video, which was developed animation by us to how the cysts are proliferating.
Role of vasopressin in ADPKD progression. The two key mechanisms of cyst growth in ADPKD are cell proliferation and fluid secretion. These mechanisms are mainly driven by elevated levels of cyclic AMP, a secondary messenger, in cystic renal epithelial cells. In ADPKD, cyclic AMP promotes cell proliferation via the activation of several pro-proliferative pathways, as well as chloride-driven fluid secretion into the cyst lumen. Vasopressin, also known as AVP or ADH, is an antidiuretic hormone that is a powerful modulator of cyclic AMP activity and thus plays a critical role in ADPKD cyst progression. Physiologically, vasopressin promotes water reabsorption via aquaporin channels in the collecting ducts of the kidney. However, vasopressin plays a different role in cyst-lining epithelial cells, promoting cyst growth. Both vasopressin and vasopressin V2 receptors have been shown to be elevated in ADPKD. Vasopressin binds to vasopressin V2 receptors in renal tubular epithelial cells, resulting in elevated cyclic AMP levels within the cells, and the activation of cell proliferation and fluid secretion. Vasopressin, acting on V2 receptors, has been shown to be the main hormonal regulator of cyclic AMP production in cystic renal epithelial cells, resulting in an increase in cell proliferation and fluid secretion, which drives cyst growth. Over time, the progressive growth of these cysts contributes to an increase in total kidney volume, accompanied by destruction of kidney tissue and progression to end-stage renal disease.
This is such a fascinating video that we had, and I'll go over with you the story when we were doing this basic science research. When I was a fellow, I did both adult and peds combined. First thing we thought that maybe the cyst is growing is, I understand it's because of the disruption of the polycystin 1, polycystin 2. Maybe it's because of that there is no calmodulin, the calcium is going down, and there must be just activation of the phosphodiesterase inhibitor. Then somebody said, well, we looked into all these cysts. It is very much rich in cyclic AMP. And Dr. Mithwani may know, going back in the older time, Dr. Schreier used to say you have to drink 2 liters of water, no caffeine product, then your kidney size were going down. What was the rationale behind that? We learned it during the sequence of this molecular test. We found out he wants us to drink 2 to 2.5 liters of water to decrease the renal cyst because you want to suppress the vasopressin. And why the data shows that you avoid the caffeine product because of the increased production of the cyclic AMP because of the phosphodiesterase inhibitor. Then we found out there was also an overlap of this cyst proliferation with mTOR inhibitor, and maybe there's something, not only the activation of the vasopressin with V2 and increasing the cyclic AMP and mutation of the PC1, there is something which is causing the proliferation and dedifferentiation, and maybe there is a lack of the fluid secretion going out of the cyst. Imagine these are individual cysts in the tubule. They are multiple. And this is how the thought process worked. And I was sold out when I was doing this research. This is because of the sweat chloride mechanism. Maybe the chloride is not letting the fluid secretion, the cyst is growing up. And it is so fascinating to see each cyst are individual. They grow by themselves, and they have a lot of V2 receptor. Now, how did we prove it was all V2? Because cysts in ADPKD derive predominant from the AVP-sensitive tubular segment expressing multiple V2 receptors. If you take this cyst from the surgical pathology loaded with V2 receptor, each cell. And AVP acting on the V2 receptor is the main hormonal regulator of the adenylate cyclase activity in a freshly dissected collecting tubule. And circulating level of AVP were increased in a human ADPKD and in all animal model where we have seen it's certain to be ADPKD. And the cyst epithelials are persistently stimulated to proliferate and secrete fluid due to this elevated AVP. We knew it was a V2 receptor. When we came to know that, we were cross-talking with Dr. Bill Torres and other people in the Mayo, and I was like, really? It was V2 receptor? And we were targeting the mTOR inhibitor. We were looking into the chloride secretion. We were looking into the cyst. This was a fascinating discovery. And it was not only shown in the transitional research, but it was also the specimen. These cells were independent, water secreting V2 receptor via cyclic AMP. Then going back to this theory about before the drugs were developed, it is a common progressive inherited disease which involved the development and the progression of fluid-filled cyst. And we found out that the vasopressin is a powerful modulator. Cyst and kidney growth in ADPKD actually precede the changes in the renal function. And patients with ADPKD may remain asymptomatic for years while the disease progresses, and it is associated with renal and extrarenal manifestation. You need to know this is a burden to the healthcare resources. As I showed you the stats before in the US after diabetes, hypertension, or any atherosclerotic, this was the cause of the ESRD. Now, how would you assess? This was the biggest concern we have, because you can have a patient with kidney size of 16, GFR hyperfiltrating 116. How would you say that this is ADPKD disease progression? What are we going to do? The problem is you will have a normal kidney. You start producing the cyst. You have hyperfiltration, which is bad. After that, you impair and the kidney falls. So the problem is patient identify being at a risk of rapid progression are those reached to the ESRD at earlier age than expected. And nearly 50% of the patient with ADPKD was reaching to the ESRD around 60 years of age. Now, this is a nice diagram, the biomarkers. And I want to really spend some time because this was the paper and the study that we did. We look into what are the predictors of rapid ADPKD. And I'm not going into the molecular marker. I'm not going to the I'm not going to the MLP1. Environmental predictors were high caffeine. And I showed you the reason was cyclic AMP production. High protein intake was also thought to be associated for ADPKD production. And we found out that maybe it has something to do with hyperfiltration. Low water intake. Why? If you take less water, your ADH is not suppressed. More ADH will go to the V2 receptor, you'll fall cyst. Smoking, fuel in the fire, fuel in the fire. Now, we looked into the imaging predictors were high total kidney volume and low renal blood flow. Let me give you my story. I was a fellow. I saw a young patient, 21-year-old girl, came to us to get evaluated with the ADPKD. She has 2 large ADPKD kidneys, and each were like 20 centimeters. Like she technically is carrying a twin in her belly. I saw her in the clinic. I was a fellow at that time. And what happened was that she saw me, and that the traditional treatment was to give them a low ACE inhibitor. Her creatinine was like 0.9 when I saw her. I put her on a low dose of ACE inhibitor, which was like 2.5, and I sent her home. 2 days later, I get a call from the ER for the same patient, and the creatinine was 13. And I was like, what happened? I went on, talked to my mentors. We looked into the renal Dopplers. She has such a low renal blood flows to the kidneys because both kidneys were hanging down. So the renal arteries bended, and she has a very high resistant indices because of the size of the kidney. And only thing that's maintaining the perfusion was the rennet, because kidneys were shouting, for the impaired blood supply for renin, and I shut it down with the ACE inhibitor, she went into complete renal failure. The data has shown high total kidney volume, which I'll come and I'll explain, low renal blood flow, resistant NCTs being high is image predictors for bad ADPKD. Early onset of hypertension, gross hematuria, early decrease in eGFR. Now there is a new thing evolving, which is PKD1 truncated mutation. And you can actually ask them in the rapid progressors, they will give you the data shows that you have a larger pieces of the PC1 was truncated and they go into the ESR very fast. Laboratory predictors are overt proteinuria, bad sign, microalbuminuria, and there is an elevated copaptin. And this is more like a laboratory things we have done in our models. Copaptin is actually a byproduct of the vasopressin because you cannot measure vasopressin. It actually calculate, or it is a surrogate marker of high level of the vasopressin. Now, this is what the PKD consortium was, which I have shown you is known as the critical path of success. 2013, they were developing of the therapeutic area. 2015, FDA letter of support was given. At that time, at the end, we were like talking about how the total kidney volume should be the surrogate marker, not the creatinine. And then 2016, the FDA quantified that TKV as a prognostic biomarker for FDA in the form of final guidance, and they designated total kidney volume as a reasonable likely surrogate endpoint. Because the problem was when you are developing all these successful quantification for the ADPKD, we were saying that total kidney volume is a prognostic biomarker to select patient for clinical trials for new therapy for ADPKD. It's a key milestone for the consortium because most of them, and you all know that the creatinine is fine, but they have if you look into the CRISP trial, if you have a kidney size of 14 centimeters, you are CKD3. And this was a big thing for our critical path for FDA to approve. Let me show you the value of total kidney volume and how does this is exactly be presented to FDA, the value of surrogate progression on the base of total kidney volume, not just creatinine or other things.
Assessing disease progression with eGFR and TKV. The estimated glomerular filtration rate, eGFR, is commonly monitored to assess disease progression in ADPKD. However, kidney function may appear to remain within a normal range for several decades, even as the kidneys become significantly larger and irreversible damage is occurring. Recent research has suggested that in addition to monitoring eGFR, assessing baseline TKV may help to identify patients at the greatest risk of rapid disease progression.
And this is what was taken very carefully by the FDA. It's the total kidney volume. This is our paper came out in Nature, which we have looked into the database for the adolescents and young adults looking into the rapid progression. And this is how the base model of the total kidney volume with the eGFR was tested. Now, what we did, now you have a formula. If you put the length, height, and the depth, you can correlate the total kidney volume because total kidney volumes are generally generated in the study by an MRI. And these are the two base models that captured the overall trend of the total kidney volume and the eGFR. And what we did was the Bison information criteria with model 1 and model 2. It was very predictive that if you have a high total kidney volume, you will progress to ESRD very quickly and you do bad. Now, this is a longitudinal model indicating adequate performance both from the fit perspective and predictive availability. eGFR and total kidney volumes were like splayed around. So if you have a high total kidney volume, your eGFR is going to be slowly down, but there is a lag between the total kidney volume going up to the eGFR. By the time you hyperfiltrate and your eGFR gone, you are already progressed, and this is what the longitude fit model was. This is the TKV based classification. If you can take one thing from this lecture is this diagram, and I'll give you an example of some of the patients. So I have a very smart, well-known patient who came to me and he said this was his fourth opinion. That's what happen when you are in Cleveland Clinic. People come for second opinion, third opinion. And he came to me and he said, well, I saw like 3 patients and I was a male. They want me to get started on the medication. I don't think I have any problem. My creatinine is fine. I have very little protein. I'm doing well. I'm very active. So I said, okay, let me look into your ultrasound. So I looked into his ultrasound. He has 15 centimeter kidney. And in my mind, I did the CRISP trial. I said, you're already CKD3. So I said, let's sit down with you and have your height adjusted TKV with your age and see what's going to happen. So he was 30-year-old and his kidney size was around 16 centimeter. And I calculated he was class 1C. So he's 30 year here, and you can see his 1C, his total height, total kidney volume was around like 900 or something. So he was almost, 700, and he was almost going from 1C to 1D. I sat down with him and I said, your kidney size is very big. You are a tall guy with your kidney volume of 15 centimeter. I put it in the computer. You are already not only 1C, you are encroaching towards 1D. So your kidneys are going to grow 6 centimeter per year. Your GFR will go down to -348 1 year, and you are rapid progressor. Let me give you another example. I have an 18-year-old kid who came in positive history. Father got transplanted, doing well. He has some cyst in his kidney, and he's around 19-year-old, and parents were very worked up. I think he was PKD1, and I looked into his kidneys. He was 12 centimeter, and he was young kid with 20 years, almost 19 years, and he was coming out to be almost 1B class. So I said, you will have a less growth of the kidney. Your total kidney volume with the height is falling in a 1B. You will lose your GFR slowly. You are intermediate. We will not start the medication. We'll watch you in a year, and then we'll see how you do. In that way, you can progress or not. The time will tell. So this is how we went to the FDA. We explained them it's not the creatinine. This whole prediction model has nothing, just the total kidney volume divided by your height. And I'm happy to share in the email to Dr. Al Hassan and Dr. Mutawali about how to calculate. There is all the QMD apps you can calculate. We never talk about the protein. We never talk about creatine. We only talk about total kidney volume. And this is the structure. I show you the critical path, how important it is to sit down and counsel the patient. MRI is the recommended imaging for the measurement of kidney volume. Ultrasound-derived kidney length has been proposed as a surrogate MRI marker for predicting CKD3. Now, these are the investigator analysis of 241 patients with the CRISP study that we have done, and Cleveland Clinic was a part of it. Reported best cut point for the prediction of development of stage 3. Kidneys length more than 16.5. Height adjusted kidney volume 650, you're already stage 3. You're already stage 3. I don't even have to talk about anything else. Kidney length alone is sufficient to stratify the risk of progression to renal insufficiency early in ADPKD using an MRI or the ultrasound. Height is considered an important variable in the measurement and in interpretation of kidney volume. This may be important. Limitation of the US-based kidney predictive volume of 16 centimeters. I was doing the roundtable with some of the people, and the pediatricians were there, and I was talking to them. And in the roundtable, they came up, oh, I don't think 14 centimeter, the patient is going to progress. She's 16-year-old. And I was listening to them. I said, I don't know why we are debating. If you have a young kid with 16 centimeter of ultrasound, he or she's already CKD3. And everybody's like, what do you mean? I said, yes, there is no way you're going to waste your time looking into the creatinine, albumin, and other factors. Your patient, 16.5 centimeter, if it is 16 or 17-year-old, he's already 1E. He's already stage 3. What are you waiting for the patient to start the medication for? So just to summarize, it's a progressive disease, cyst growth, perceived declining the kidney function. And this is how the rate of the predictions are. Predictor, for the rapid disease progression include radiographic parameter, total kidney volume, genetics, family history, clinical indicators, and laboratory parameters and biomarkers. Prognostic tools such as TKV-based classification of ADPKD may help patients for the risk of rapid progression before they go to the ESRD. Then it comes GnRQ. It was a selective V2 receptor antagonist, which is indicated to slow the kidney function decline in adult for the RP, for the rapid progression. How this whole structure of the talk is in the US, when you do the talk, the first thing you tell them is that, what are the side effects? It's just going back. When you go to the FDA, it's like, how are you going to deal with it? The biggest issue was the transaminitis. And this was something as a black box warning. We were very careful. We were doing the ALT, AST at 4 weeks of association. This is how the drug was. It inhibits the V2 receptor. It binds and decreases the cyst proliferation. Not only that, it causes decreased cyclic MP, reduced cell proliferation, and slows the kidney function. And this is the nice diagram. How does GnRQ works for ADPKD? And this video explains the whole mechanism.
GnRQ, Tolvaptan mechanism of action. GnRQ is the first and only FDA-approved treatment indicated to slow kidney function decline in adults at risk of rapidly progressing ADPKD. GnRQ, a selective vasopressin V2 receptor antagonist, prevents the binding of vasopressin at the V2 receptor in renal tubular epithelial cells, which results in decreased intracellular cyclic AMP concentrations. By reducing cyclic AMP levels in these cells, GnRQ reduces the rate of cell proliferation and fluid secretion into the cystic lumen, which in turn decreases the rate of cyst growth, ultimately reducing the decline in eGFR.
And that,
please see full prescribing
that
information.
was the thing started with the reprise and tempo. And I did CRISP, I did reprise and tempo. Let's go over the trial. And I think it's very important for you to know the difference between reprise and tempo. And I'll give you a very simple example. Reprise trial came out, which was we did Tolvaptan and placebo. But the problem was in the reprise trial, we picked up we did different than tempo. Tempo was very simple, but tempo showed that, tempo was easy one. We picked the cherry pick, the one with ADPKD, with have creatinine clearance of 60. They are doing good. Their kidney volumes are 750, and the drug showed it is effective. We went to the FDA and said, well, we have this 1,445 patient. It's working well. We did the randomization 3 years. FDA came back to us. No, you did this, but these patients' kidney functions were normal. If it is effective, go back and show me it's going to be effective in a patient in a GFR stratification below 60. That's the reason we did reprise. And reprise actually have patients with a GFR between 25 to 44, or they have an evidence of decline more than 2 ml per minute in per years. So this is the difference between tempo and reprise trial. And reprise was a very amazing trial because we have patients randomized from eGFR of 25 to 65. I have a patient I randomized with an eGFR of 25. I went to my chairman. I said, I'm so scared. He said, what's going to happen? He's going to be in dialysis in 3 months or 6 months or 1 year. I enrolled that patient and he did well on the reprise trial for 3 years. His kidney volume, everything stabilized, he got better. I gave him 5 years before he got transplant. So that's the difference between tempo and reprise. And I think FDA was totally right. If it works, you cherry pick with a good GFR. Give me a reason if it works in a low GFR, and it did. This is how the structure was. You do screening, you do placebo run-in, Tolvaptan for 2 weeks, you go for 30-15, 45-15, 60-30, 90-30, and then you do 3 weeks of that, and then you go double blind for 12 months. And this was the endpoint. What was the value? This is just a matching of the GnRQ Tolvaptan with placebo. There was no difference. The best thing, you can see how nicely it is. You have around 139 patients with CKD4, and you have around 303 patients with CKD3B that were enrolled in the reprise trial to show the value of Tolvaptan. beautiful response, 35% reduction in decline of the kidney function compared to placebo with GnRQ. And these are reprise trial, 25 to 65 GFR. Second response we saw, this is age, gender, race, baseline CKD region, all patient. There was subgroup analysis, nothing was matching as compared to anything else. Now, this is a very, very important slide. So how I start the patient in Tolvaptan, I get a lot of patients because some of them were in repeat, some of them were on the trial before. You bring them, I said, if you want to start the medicine, you have to do 3 things. And they said, Dr. Rana, what? I said, first of all, in the night, you have to put an alarm and make sure you get 2 or 3 times in the night. Every time you get up, you pee and you drink 2 glasses of water. During the day, I want you to drink 3 to 4 gallons of water, 3 or 4 liters of water. Make sure you can pee and you don't get tired. This is very important to precondition them. Now, these are the side effects, and I lay down in front of the patient. You will have polyuria, yes, because that's a mechanism. You will have nocturia, be more. You will have thirst, you have polydipsia, diarrhea, sometimes fatigue. And the good example I gave fatigue is because you're peeing, going to the bathroom, you will get fatigue. But if you see the difference between the GnRQ and the placebo, the renal pain, the back pain, UTI, peripheral edema, headache, viral-related URI, I don't know why that was included, much better on GnRQ. And I will tell you, I have a patient who was pregnant, had a baby, did well, and after 3 months, she was not feeding, she was not doing the breastfeeding to the kid. And she said, Doctor, I want to be back on the medication. I said, why? Let's give us some time. She said, my pain is coming back. And the good scenario, what one of my younger patient told me, I think my kidney is like a bubble wrap. I could see the cyst forming and it gives the pain. Pain was much better on these patients. The cyst size is at least stable, not going down. They feel light, no UTI, no back pain. These are the things which was very, very effective on the patients with the GnRQ. And I'll tell you, these patients, they don't mind to be polyuric and nocturia because they feel that helps them to have a quality of life. Now, this is the discontinuation rate. Very simple. Aquaretic effect, 4.6 people that drop out of the reprise trial because of peeing a lot, which is nothing as compared to others. And only 5%, 5 patients have liver issues. And this is another very, very important thing that you need to know, that you need to stop the medication if your ALT is more than 3 times of upper limit and then wait. But if it is more than 5 and 10, you get more scared. Now, we looked into the subdoc analysis of the TEMPO trial, which is also based on this. And these TEMPO trial patients were all doing well. Their GFR is around like 60 and above. We want to compare reprise with TEMPO to see maybe there is an issue with TEMPO. They are doing well. Reprise have more liver injury, but there was not much difference in any of these reprise versus the TEMPO trial. The thing that we look with comparing both TEMPO and reprise trial was there is multiple things that showed not only the change of the total kidney volume or the GFR, worsening kidney function defined as persistent 25 reduction in the eGFR, they were better. Medically significant kidney pains were better. Worsening hypertension got better. Worsening albuminuria got better. Some of the people say, oh, they're peeing a lot. It's very diuretic. But you quantify with the creatine, just a ratio. The other thing is the kidney functional slope with the GFR was very, very important. So when we went back with the reprise and the TEMPO trial, we said primary endpoint was total kidney volume. But these are the key secondary points. And the third point is the kidney GFR. That just made the medication got approved. These are the baseline characteristics for the TEMPO. What a beautiful display in TEMPO that 49% of 49% reduction of the rate of change of TKV at the end of 3 years. Month of treatment was 9.2%. The difference in the total kidney volume treatment will mostly depend within the first year, and the earliest assessment within the little further difference in 2 to 3 years. Huge difference between placebo and Jynarque. And if you think this is not huge, talk to the patients, how the cysts proliferate, pain, what they feel. They have a dragging pain. And many times people say, oh, he's the pain dependent. I say, what are you talking about? He's forming the cyst. It hurts. Kidney has nerve ending. This was changing the total kidney volume. See what was the response. It is just not the secretory effect. There was a proliferative effect. As I shown in my slide, it was very, very effective. 13.5% reduction of incidence of overall composite score, hypertension, albuminuria, renal failure, renal function, 61% reduction in the risk of worsening kidney failure, and 36% reduction in likelihood of being brilliant pain event, which was very important for us to look. There was 26% reduction in the rate of kidney function decline in extension trial. eGFR difference produced by the third year of TEMPO 3-4 were maintained over the next 2 years of Jynarque treatment. So it's just not one time, it maintained on the longer time too. These are some of the side effects: urination, diarrhea, dry mouth, and other thing. Now, what is more important was that dyspepsia, they feel like after drinking a lot of water, they eat less. But you see the difference? It was not big between the placebo and Jynarque. Treatment emergent adverse reaction was 3% treated subject with the risk difference of 1.5%. And this is very, very important. Now, the whole saga of this ALT, AST was bring up big time. And I'll ask you, most of the people, they get the Lipitor, they get a lot of anti-hyperlipidemic. The chances of getting a liver affected, that is 10%, but we never ask. But this was a huge thing for us because in our case, it was 5%. So we came up with what is known as the Hayes law. And this is very important. First is the total kidney volume, how to calculate the graph for the rapid progressor. But if you get abnormal LFT, you need to follow the Hayes law. When ALT is more than 3 times of the upper limit normal of the whatever your lab value, the bilirubin more than 2 times of your lab value, but ALP less than 2 times of an upper limit normal, then you have to stop the medication. And I do not look at ALT, I look at the Hayes law. It's very well depicted here. It's also in my papers. I'm happy to share that. When you have high liver functions, you have to calculate the Hayes law, stop the medicine for 3 to 6 months and start with a lower dose. This is how the efficacy and safety is. Reprise decreases 1.3, tempo 1. Tempo and Jynarque significantly reduce the rate of total kidney volume, 49% over 3 years, and ADPKD relative adverse event was 13.5. 3 years open extension label was done. Most common side effect that we did in open label was thirst, polyuria, nocturia, pollakiuria, and polydipsia. So pollakiuria is you just have free water. What I do is when they come and wait in my office, they use bathroom 2 times. Always take their urine and dip a stick it. If it is specific gravity is 1005 below, they're taking the medicine. And they're very, very meticulous on that. So these are the Reprise and the Tempo trial, and loss of the kidney function in Reprise is reduced by 35%. Tempo, CKD 1, 2, 3, total kidney volume growth slowed in 49%. Tolvaptan has little effect on kidney size beyond what occurs during the first year of treatment. The relative rate of ADPKD-related events were decreased by 13%. The total kidney function decline was reduced by 26%. This is a paper that came out, and this is the first paper in US. We went to Tempo 3-4, and we look into the adolescent, young patients, and these patients were 18 to 24 years, same response. Their total kidney volume was better as compared to 25 to 50 years of age. There were very less side effects with the liver. And I have a lot of young patients who take this medication. This was the one that was the first study done in Nature, in clinical research, and people cite this article a lot for the adolescents. This Tolvaptan got approved in UK, not with us. Same thing, same data showing not only the total height over KT over V, They also found a change in the GFR. They also find the aquaretic side effect. Exactly what was done in the adult was replicated in pediatric. Unfortunately, in US, we cannot give less than 18 years. The medicine is not yet approved. There's a beautiful article that came out in Drug Health and Patient Safety, at which we have shown the clinical utility and tolerability of the tolvaptans in treating ADPKD. These are some of the trials. I don't want to go in detail, but this is a slide I really want to leave it for you to tell you the cyst is not easy. I'm still looking what are the factors that causing the cyst proliferation. There's new thing we are looking. We looked into the urine endothelin and the creatinine ratio and saw the ADPKD cyst size. This is another thing. Maybe urine endothelin is causing, endothelin level A may be causing the cyst growth. So new drugs are coming into the market for endothelin blockers. You must have heard about IgE and FSGS. Some of the last slide, I'll quickly say that SGLT2 was used in ADPKD, not much very response. There was not as effective as tolvaptan. Then we have this medication that they came out, there was a very little effect. They talk about ketosis in therapy for ADPKD, transitional research in pipeline, very minimal effect. We talk about venglustat, which is actually a glucuramide synthetase inhibitor. Again, going back to my initial slide, these are all the receptors we are still targeting, and there was very little effect. It didn't show much improvement in the cyst size. And then there's a lot of things people talking about metformin, and metformin was a little bit improves the relevant disease parameter in ADPKD. Polycystic in the mouse model. In the human model, there was not very strong evidence. We talk about curcumin. This is some of the spices very commonly used in India, and people showed that maybe this is ongoing trial is effective or not, but this is also not replicated in the way things are. So niacinamide is another vitamin B3 available over the counter, and they thought it inhibits a regulatory protein called sirtuin, and it is effective, but there was no observed benefit. With that, I want to end my talk, but I think it's very, very important for you to understand metformin, curcumin, these are all ongoing. People come and ask you the effectiveness of that. Tolvaptan works, and it is a marvelous discovery. I wish in the US we can give it to less than 18 years. It's going to happen because UK already got the data out. And when I was reviewing the paper and I was reviewing the literature and everything, I got this data from UK. I said, wow, this is effective in children. But there is a problem. Even if you have a hyponatremia in your hospital, if you give SIADH 50 milligrams, you need to be comfortable giving 90-30 or 60-30. The dose of this is pretty high. So recap, do the total kidney volume, adjust it to risk prediction, look into the Hayes laws, and effect is maximum in a year. It's sustained for 3 years. Even after that, it's sustained for 2 years. And again, I want to thank you all for giving me an opportunity, especially Dr. Khalid Al-Hassan. He has been a great instrument for our relationship with Saudi, and he has been an integral part of our PCRRT. He's one of our board members, and we have done a lot of work together, and we have used a lot of his insight in developing our foundation. And with that, I will be ready to take any questions.
Thank you very much, Dr. Reina. That was an excellent talk. I have a few questions here from the audience.
Yeah.
So Dr. Lujena Sayed is saying, thank you for the great lecture. She's wondering, in the case of liver toxicity induced by tolvaptan, can we re-challenge again once those resolve?
What a beautiful question. So you can do the Hayes law, and great question. So I have around 9 patients that they have a high ALT, and in US, it's a REALMS program. So if we don't do the liver function test, the medicine doesn't come to their home. And if it is LFT is high, it automatically shut down. You hold that for 2 to 3 months, 4 months, start with the lower dose, 30-15, and see it comes. I have started 9 out of 8, the medication, and they do well. Be careful. They have a liver cyst. There's a patients who also have some NASH, so it just potentiated. But the incidence in the studies, in the tempo and reprise I showed you, it was less than 5%. So I always tell the patient, your risk is 10% with the Lipitor as compared to 5%. But you can always re-challenge and keep them in low dose.
Thank you. I'll go to the question specifically for Tolvaptan first, and then I can go back to the general questions. So Dr.
Okay.
Abdulhamid is asking what target serum osmolality would you go with the treatment? I'm not sure if you meant maybe urine osmolality, because there was that KI paper in January.
I do not. I do not watch the osmolarity and urine. What I do, it's easy for you when they are in your office, dip the urine. If it is less than 1005, they are matching, they are taking the medication. I know there's data from the UK. They are very persistent about looking into the urine osmolarity. The compliance, you can read it very well. They will be peeing a lot. They have a log of the urine output diary. They'll be sitting with a bottle of water. I generally do the specific gravity in-house, dip it a urine, less than 1005. They're taking the medication. Second thing is the data from the reprise and tempo was never being correlated with the urine osmolality. Because one thing you have to understand, it's an allosteric inhibition of the V2 receptor. So, and I showed you in my slide and in the video, it decreases the V2 to come and attack. And secondly, it decreases the cyst proliferation too. So urine osmolarity just tells you the compliance, but what amount of medication is doing the allosteric inhibition, decreasing the cyst proliferation, can only be quantified by doing a serial ultrasound and looking into the cyst. That answers your question.
Thank you, doctor. Same doctor also asking about the role of metformin and ACE inhibitors in potentially decreasing the thirst associated with Tolvaptan. Have you had any experience with that?
Why you should decrease the thirst for the Tolvaptan? You'll make them hypertensive.
Yeah.
Let them drink. If they don't, what is the mechanism? They want the ADH to be suppressed and decrease the cyclic AMP. Why you want to decrease the thirst? They'll get hypernatremic. And the chances of hypernatremia was less than 3% in tempo and reprise. So don't, please let them drink because they are suppressing their ADH and they are also inhibiting the V2 receptor by Tolvaptan. It's a double mechanism and the cyst size grows. Now, ACE inhibitor, there is a role on ACE, mainly in the setting of albumin.
I think the video froze for Dr. Reina. We'll just give him a couple of minutes to join.
Yeah. Data which shows that the of metformin.
Dr. Reina, sorry, we lost you for a few seconds there.
Okay.
You were just starting to talk about the utilization of ACE.
Can you hear me now?
Yes.
Yes,
Thank you.
yes.
ACE is important in the setting of albuminuria, but there's no data on the kidney volume and an ACE. Second is metformin. There's no data of metformin and total kidney volume. But ACE, you can use very low dose, 2.5, for targeting the blood pressure. Don't use the calcium channel blocker like amlodipine and all. It can proliferate the cyst.
Okay, thank you. Dr. Majid Al-Aufi is asking if you had the ability to use it in a pediatric patient who is diagnosed before the age of 10, when would you start the drug?
Very good question. And this is exactly what FDA came up with. Why should you use in the young patient? But if you look into the data from UK, it is very effective. I showed in my study from 18 to 24, it's effective. I don't have the right answer, but anything about 7, 8, or 9 years, when they have the ability to recognize that they can drink water, then I will do it. But remember, they have to be a rapid progressors. You cannot just give anybody who walks in your office with 2 cysts in the kidney and you say, hey, I have an ADPKD, I want to take Tolvaptan. Tolvaptan is approved by FDA for rapid progressors. So in that case, about anybody who sends like 8 or 9 years is a very good time. But that's exactly, you just nailed it. That's the question FDA has, how safe it is. How are you going to manage in a young children? What a good question. But in UK, they have used in children. It worked out well.
Amazing. So another anonymous question. I guess they're asking when would they stop Tolvaptan as the patient progresses towards dialysis? I guess would you stop it as they are actually being set up to start on dialysis or a little earlier when they're kind of uremic and you're getting the lines in and all that?
these are my questions for my clinics. Yes, so I told you about a patient. I have enrolled 7 patients who are GFR 25 to 30, and we gave them around like 6 years on trial and on medication. Then GFR was like 15. 2 of them got preemptive transplant. The other one started on dialysis. You'll be surprised. This is not diabetes or hypertension or chronic interstitial changes. These patients can have a creatinine of 6, being a lot of urine, still get better over the time, and they may not progress too fast. Secondly, these are young patients, so they have no other comorbidities. So some of the patients' eGFR was 15 to 20, they still continued for a longer time. But once you start them on dialysis, yes, you have to stop the Tolvaptan.
Maybe I'll just give this one last question, if that's okay. Dr. Babikar Al-Tayyib, sounds like he actually knows you since he says Rupesh. It's Al-Tayyib, nice talk.
Yes, I know Dr. Al-Tayyib very well. He was the one who hired me in the job, which I'm doing now.
Oh, that's great. But he's asking, do you recommend genetic testing on all potential kidney donors from families with ADPKD at any age?
Very good question, and that's true. Because as I said before, he's right, because some of the time the cysts are so small, they're microcyst, so they do not get bigger. So you need to do an MRI. I will suggest to do a genetic testing because you do not want to take a kidney from the family, and especially with truncated mutation, because maybe they're younger 30, they're not manifesting the ADPKD full blown, but down the road you will. Yes, I will definitely, and it's very easy. I don't know that you have, Dr. Mitwali will tell me, or Dr. Al Hassan, that you have the Natera genetic testing where we swab the mouth, like how you brush your teeth, and then you send it out so you can get the whole gene sequencing from that. I will recommend 100% to do it. And we don't take relatives unless we have identified that they are not carrying the gene. And it could be PKD2 too, but you don't want to take the kidneys from them. That's a very right and perfect way of practicing.
And that's been the local experience as well. We typically test the donors of any ADPKD patient presenting for transplant. It's actually where we recruit most of our patients. Our center is mainly transplant-based, so if we see someone that's too late for them, that we try to recruit from their families. So yeah, so that's often where we see it. I think part of another hidden benefit for Tolvaptan in my book is that the kidneys aren't as big as they could have been. So avoiding having to do a nephrectomy prior to transplant is another major benefit too.
Right, that's true. And first of all, and the other thing is, that's so nice, Faisal, you brought that up. It has no role on the liver cyst. So do not even think that the liver cyst will get better with the Tolvaptan.
Do you see any changes with other extra renal and hepatic manifestations? Any benefits demonstrated?
No, FDA is very clear. No. And the other thing is, people have a lot of questions when if they have a aneurysm, it's going to burst with ADPK. There was no correlation with the intracranial aneurysm rupture with the use of ADPK with Tolvaptan. There was no correlation. But no other extrarenal manifestations has shown any effect on Tolvaptan. It's very specific to the V2 receptor in the kidney tubules.
Last question, Dr. Tariq is asking if your approach to polycystic kidneys in infants is different from those in adults, or does it need to be significantly different in adults? Yes.
Huge difference. You can see all my papers. I'll share. The differential diagnosis is very, very different. And HNF beta 1 mutation has been surfacing out a lot in children. Total different etiology in the neonatology. You can have a differentials of multiple differentials for renal cystic disease as compared to what you see in adults. So you're totally right. Happy to share my paper. And that point of the time, you have to look the whole logistic, just not the kidney. And I told you, I saw like Bartle-Beetle syndrome. I saw the Ivermectin kidney. I saw the VHL. You're right, and nephronophthisis. And I have just seen a kid who was like 8-year-old, came in, has a cyst when he was born. Nobody followed. Anyway, long story short, kidney size was very small by the time he came to me. He has anemia, short stature. And I looked, I said, this is juvenile nephronophthisis. And I did the testing. It was juvenile nephronophthisis. So you're right, the spectrum in peds is very different.
Perfect. Thank you very much for the great talk, Dr. Raina. It was a pleasure.
Thank you. Thank you again for inviting. And my special thanks to Professor Khalid Al-Hassan, and also my special thanks in regard to Professor Ahmed Mitwali. I still remember my time in Riyadh. It was beautiful. Your hospitality was amazing. I felt that I was at home. And thank you again for inviting me, and wish you all a very happy Ramadan and upcoming Eid.
Thank you. Thank you very much, Robish, for joining us today and immediately accepting our invitation as usual.
Always.
And so
I
we
cannot say
highly
no to you, Khalid.
thank you very much. We highly appreciate it. Really, we highly appreciate it. So it took me just minutes talking to you. Thank you very much. Thanks also, Faisal, for your excellent moderating this session, and looking forward for another future meeting. Don't forget our big Congress in December. So again, Professor Robish Reina will be with us in December. Before I end, I would like to thank the sponsoring company, Spimaco, specifically Ahmed Thabit.
هو مطلوب منه يسوي أي مجهود.
So
اللي يبغى يسويه هو اللي يبغاه وسهل الحمد لله.
Thank you very much, Spimaco, for sponsoring this event. Without your support, the event wouldn't be happened. So thank you all our attendees. So I would like to disclose that concurrent attendees is reaching about almost 4,900, which is one of the highest records on attending. So this is tell you how the importance of the topic and how terrific talk by our highly cited speakers. So thank you very much. Have a wonderful Ramadan and 10 أواخر مباركة. See you everyone.
Khalid, can I ask Dr. Robisho one question? What is the effect of ADH or Tolvaptan on a patient with also, along with his polycystic kidney disease, he has like almost cardiac failure?
What a good question. What a great question. So this is something I would have addressed, but I did not because of the time. So Dr. Mitwali has really, really brought a very nice issue with the patients. So they get some left ventricular hypertrophy, they get mitral regurgitation. So it's benefit also because with the heart failure, it helps in the free water diuresis. So it's very effective in the cardiac remodeling. And thank you for bringing that up, because we looked into our databases with the patient with the heart failures or left ventricular stiffness. Because of the free water aquaretic effects, their cardiac remodeling was also benefited, but in adults, not in peds. I'm talking in adults. So that's a very good point. It really helps a lot in the patients with the cardiac remodeling.
That's tell you the experience. That's why he left this question at the end. So so thank you very much, Professor Mitwali. Thanks Robish. Thank Faisal. Thank everyone. So see you later. مع السلامة.
يعطيك العافية بروف خالد.